Dr. Harrison couldn't stop smirking when he spotted the tattoo on the new nurse's forearm. What ridiculous military nonsense, he laughed loud enough for half the emergency department to hear. The intricate design looked like wannabe soldier playing dress-up in scrubs to him. Maya Rodriguez kept her eyes down, continuing her work. She had heard worse. What he couldn't read were the subtle symbols woven into the design. Symbols that would make most military personnel straighten their spines and show immediate respect. Director Wilson happened to walk by at that exact moment. His face went completely pale. He recognized it immediately. "Special Operations Leader," he whispered under his breath. But what happened in the next 4 minutes would change everything in that hospital forever. Because sometimes the quietest person in the room is the most dangerous. And sometimes a ridiculous tattoo tells a story that can save lives. Stay until the end. You need to see this. Where are you watching from? Drop your location below. 3 hours earlier, Maya Rodriguez's Ford Ranger had pulled into the employee parking structure of Seattle Grace Trauma Center. She sat in the darkness for several minutes after killing the engine hands still gripping the steering wheel, watching rain streak down the windshield in the amber glow of sodium vapor lights. The transition was supposed to get easier. That's what the Veterans Affairs counselor had told her during their last session. Give it time, Lieutenant Rodriguez. Civilian life has a learning curve. Nobody prepares you for how different everything feels. What the counselor hadn't mentioned was that the curve felt more like a vertical wall. Maya pulled down the visor, checking her reflection in the small mirror. 31 years old, but carrying eyes that looked much older. Dark circles that no amount of concealer could fully hide. A thin scar along her left jawline, mostly covered by foundation from shrapnel that had missed her carotid artery by less than 2 centimeters in Helmand Province. She traced the tattoo on her forearm with her right index finger. The gesture was unconscious now, a habit developed over 3 combat deployments. The eagle represented Special Operations Command. The 5 stars arranged in a specific constellation marked successful high-risk missions completed under fire. The medical cross integrated into the eagle's wings was the real identifier, though. Only graduates of the Special Operations Medical Leadership course earned that particular combination of symbols. 63 people had started that course with her at Fort Bragg. 29 had graduated. The others had either failed out or been removed for medical or psychological reasons. The attrition rate wasn't accidental. Special Operations needed medical personnel who could function as the primary medical asset for an entire task force, performing everything from routine sick call to complex trauma surgery, often in conditions that would paralyze most civilian physicians. Maya wondered sometimes what her classmates were doing now. Marcus Williams was probably still downrange with the 75th Ranger Regiment. Katie Zhao had taken a position with Johns Hopkins trauma surgery last Maya had heard. And then there were the ones who weren't doing anything anymore. The ones whose names were carved into black granite at Arlington National Cemetery. She forced herself out of the truck, grabbing her backpack from the passenger seat. Seattle rain hit immediately, that constant Pacific Northwest drizzle that never quite became a real storm. Different from the dust of Kandahar Province, where she'd spent 18 months as senior trauma surgeon for Special Operations Task Force 31. Different from the blood-soaked dirt, where she'd performed more emergency procedures under fire than she could count anymore. The automatic doors slid open as she approached the emergency department entrance. Seattle Grace was a Level 1 trauma center, one of the best in the Pacific Northwest. State-of-the-art equipment. Excellent reputation. Board-certified specialists in every discipline. Everything a trauma surgeon could want. Except Maya wasn't a trauma surgeon here. She was a registered nurse. The credentialing process for military physicians transitioning to civilian practice was Byzantine in its complexity. Her medical degree from the Uniformed Services University of the Health Sciences was recognized, but her residency training had been completed under combat conditions. Civilian medical boards wanted documentation of procedures, supervision records, evaluation forms. The kind of paperwork that didn't exist when you were performing emergency thoracotomy in a cave with nothing but a headlamp while mortar rounds impacted within 100 meters. So she'd taken the nursing position 8 months ago while she navigated the appeals process. It was supposed to be temporary. 8 months in, it was starting to feel permanent. Maya. Thank God you're here. Jennifer. Park. The charge nurse practically jogged up as Maya entered the ED. We're already drowning and it's not even midnight yet. Multi-vehicle accident on Interstate 5 coming in about 15 minutes, possible overdose in Bay 3, needs monitoring, and Dr. Harrison is in one of his moods. Dr. Harrison has moods other than arrogant. Maya set her backpack in her locker, pulling on scrubs with practiced efficiency. Jennifer laughed, but there was an edge to it. He's worse than usual tonight. Just got passed over for the chief of surgery position. Apparently they went with someone from Mass General and he's not taking it well. Maya had learned quickly that Dr. Marcus Harrison was what her old battalion commander would have called a peacetime officer. Impressive credentials on paper, confident in presentation, but fundamentally untested under real pressure. He'd graduated from Johns Hopkins School of Medicine, completed surgical residency at University of California, San Francisco, published extensively in peer-reviewed journals. His CV opened every door. He was also condescending to nursing staff, dismissive of input from anyone he considered beneath his expertise level, and had a particular habit of second-guessing other people's judgment while rarely admitting his own mistakes. Maya had watched him miss obvious diagnoses because he was too confident in his initial assessment to consider alternatives. Just avoid him if you can, Jennifer advised. He's looking for someone to take his frustration out on tonight. Maya had dealt with worse. She'd operated on soldiers while indirect fire impacted less than 50 meters from her position. She'd managed mass casualty events where the decisions she made in seconds determined who lived and who died. She'd earned the right to wear that tattoo through 3 tours in some of the most dangerous combat zones on Earth. Dr. Marcus Harrison's bad mood barely registered on her threat assessment scale. The emergency department had that particular controlled chaos that only trauma centers achieved. Maya moved through it with the same calm efficiency she'd brought to forward operating bases. Check medication levels. Verify equipment functionality. Ensure intravenous supplies were adequately stocked. The work was different from battlefield surgery, but the underlying principle remained constant. Preparation prevented catastrophe. New nurse, a voice behind her, was sharp, judgmental. Maya turned to find Dr. Harrison looking at her with an expression she'd seen before. Usually from officers who'd never deployed but loved to question the decisions of those who had. Maya Rodriguez. Started 2 months ago. 2 months, Harrison's eyebrows rose. And they already put you on night shift. Standards must be slipping around here. Maya bit back her first response. And her second. By the third attempt, she managed something professionally neutral. I requested nights. Works better with my schedule. Your schedule. Harrison made it sound like a personal failing. Let me guess. Going back to school. Community college classes, something like that. The lie was easier than explaining the truth. The truth was that night shifts meant fewer people asking questions. Fewer moments where she had to pretend the sound of a dropped metal instrument tray didn't spike her heart rate. Fewer interactions where she had to act like she belonged in this world of predictable routines and reliable electricity. Harrison's attention drifted to her left forearm as she reached up to adjust an IV bag. His expression shifted from dismissive to actively mocking. What is that tattoo supposed to be? Maya's hand instinctively moved to cover it, but she forced herself to stop. She'd earned this tattoo. She wasn't going to hide it because some civilian surgeon with a superiority complex found it amusing. Personal significance, she said simply. Personal significance. Harrison laughed and several other staff members glanced over. It looks like someone threw military clip art into a blender. What are you, some kind of military groupie? Let me guess. Dated a soldier once and thought you'd commemorate it with permanent ink. The assumption stung more than it should have. Maya had heard variations of this throughout her military career. Too young to be a real surgeon. Too female to handle combat medicine. Too quiet to be an effective leader. She'd proven every assumption wrong, usually while covered in someone else's blood, and working under conditions that would give most civilian physicians panic attacks. "Dr. Harrison, we need you in Bay 2. Jennifer's interruption was a mercy Maya didn't particularly want, but appreciated nonetheless. Harrison left with one more condescending glance at Maya's forearm, still chuckling about the ridiculous tattoo. Maya returned to her medication cart. Hands steady, expression neutral. She'd learned long ago that people who mocked what they didn't understand usually revealed more about themselves than their targets. Director James Wilson made his evening rounds through the emergency department with methodical attention. At 62 years old, he'd been in hospital administration long enough to know that the best directors stayed visible. They understood ground truth rather than managing exclusively from closed office doors. He'd also served 22 years in Army medicine before transitioning to healthcare administration. His final posting had been Deputy Commander of Army Medical Command, overseeing combat support hospitals across 3 theaters of operation. He knew what real military medical credentials looked like because he'd spent 2 decades working alongside people who held them, which was why when he passed Maya Rodriguez at the nurses' station and caught a glimpse of her exposed forearm, he stopped mid-stride. Wilson had seen exactly 4 of those tattoos in his entire military career. Each time it had been worn by someone who represented the absolute pinnacle of combat medical expertise. The design wasn't something you could purchase at a tattoo parlor or replicate with a talented artist. It was earned through a selection and training process that made Special Forces assessment look gentle by comparison. The Special Operations Medical Leadership course didn't advertise. It didn't recruit through normal military channels. Candidates were identified through demonstrated performance under combat conditions, evaluated extensively, and then invited. The attrition rate consistently exceeded 50%. The graduates were medical professionals who could serve as the sole medical asset for an entire special operations task force, performing procedures that would challenge experienced surgeons in well-equipped hospitals, often while under direct enemy fire. Wilson moved closer, careful not to be obvious about his scrutiny. The tattoo's specific details confirmed what he'd initially suspected. The eagle's particular positioning, the precise arrangement of 5 stars, the distinctive integration of the medical cross into the wing design. These weren't generic military symbols. This was authentic, which meant the quiet nurse working his night shift emergency department was someone with capabilities that 99.9% of his medical staff couldn't match even on their best day. Wilson pulled out his phone, navigating to a secure database he still had access to through his retired military credentials. He entered a carefully worded query using proper authentication channels. If this was who he suspected, there would be records. Redacted in places, classified in others, but confirming nonetheless. The results loaded slowly over the hospital's wireless network. Rodriguez Maya L., Lieutenant Colonel, United States Army Medical Corps, retired. 3 combat deployments to Afghanistan. Special Operations Medical Leadership Course Graduate Class 2019. Distinguished Service Cross for actions during a mass casualty event in Helmand Province, where she'd managed 47 casualties over an 18-hour period with minimal support. Medical citations for procedures performed under fire that Wilson had to read twice because they seemed impossible unless you understood what special operations medical personnel were actually capable of accomplishing. And now she was working as a floor nurse in his emergency department while someone like Marcus Harrison treated her like a military groupie who'd gotten a tattoo on a whim. Wilson looked up from his phone, watching Maya work. Her movements had the fluid efficiency of someone trained to manage chaos as baseline operating conditions. The way she positioned herself at the medication cart gave her clear sight lines to 3 different trauma bays simultaneously. Her hands never stopped moving, but her eyes constantly scanned, assessed, evaluated potential problems before they became actual emergencies. This wasn't a nurse going through motions. This was a combat-tested trauma surgeon operating at roughly 20% of her actual capability because the civilian medical credentialing system didn't know how to process her background. Wilson made a decision. He'd been in healthcare administration long enough to know that institutional inertia destroyed talented people. Maya Rodriguez had saved lives in conditions that would traumatize most of his staff. The least he could do was ensure she had opportunity to use those skills if a situation demanded it. But he also recognized that pushing too hard, too fast, would backfire. Maya was clearly trying to blend in to transition quietly without drawing attention. He'd seen enough combat veterans to recognize someone who wasn't quite ready for the spotlight, who needed time to adjust before being thrust into visibility. He would watch. He would wait. And when the right moment presented itself, he would make certain Maya Rodriguez had the support she needed. The emergency department's rhythm continued its nocturnal pulse. Ambulance sirens wailed in the distance, growing closer, then fading as they delivered patients to other facilities. Overhead pages called for consultations. Monitor alarms beeped their electronic warnings. The constant symphony of emergency medicine played on. Maya finished restocking the medication cart and moved to check equipment in Trauma Bay 1. Her movements were economical, purposeful, each action serving multiple functions. She wasn't just checking equipment. She was familiarizing herself with the space, identifying where critical supplies were located, planning access routes and workflow patterns. Combat training never really left you. Even in a civilian emergency department, part of her brain was constantly running tactical assessments. Dr. Harrison emerged from Bay 2 looking frustrated. The patient inside had presented with chest pain, but Harrison's initial workup wasn't revealing an obvious cause. Maya had glanced at the EKG earlier and noticed subtle ST segment changes that suggested Wellens syndrome, a pattern often missed in emergency departments because it mimicked normal findings unless you knew what to look for. She'd seen it 3 times in soldiers who'd presented with chest pain that everyone initially dismissed as anxiety or musculoskeletal issues. All 3 had gone on to have massive anterior wall myocardial infarctions within days. She considered mentioning it to Harrison, but his earlier mockery was fresh. He'd made it clear he wasn't interested in input from nursing staff, especially not from a nurse with a ridiculous military tattoo. Maya compromised. She caught Jennifer's attention and quietly mentioned her observation. Jennifer, who'd worked with Maya long enough to trust her clinical instincts, even if she didn't fully understand where they came from, promised to mention it to Harrison. Whether he listened was his decision. The wall clock showed 2:37 in the morning, peak trauma hours for an urban emergency department. Bars closing impaired judgment, combining with vehicle operation domestic situations, escalating past the point of verbal resolution. Maya had learned the patterns during her time here. Civilian trauma had its own rhythms, different from combat, but equally predictable once you understood the variables. She was updating patient charts when Dr. Harrison returned to the nurses' station. He was in the middle of explaining to another physician why the Mass General candidate had gotten the chief of surgery position over him. Politics, Harrison was saying. Not about actual surgical skill or patient outcomes, just institutional favoritism and who knew whom. Maya kept her head down, focused on documentation. But she was listening, always listening. Combat had taught her that valuable intelligence often came from conversations people didn't realize you were monitoring. What Harrison was really revealing beneath the complaints about politics was deep insecurity. He'd built his career on credentials and performance in controlled environments, academic medicine where excellence was measured in publications and grant funding. But now he was facing a situation where those markers of success hadn't been enough. Someone else's credentials had outweighed his. Maya understood that kind of identity crisis. She'd watched it happen to soldiers who'd built their sense of self around being the best, only to encounter someone better. The difference was that in combat, that kind of ego usually got checked quickly. Reality had a way of revealing limitations when lives hung in the balance. In civilian medicine, especially academic medicine, you could maintain illusions much longer. The trauma bay doors remained quiet. The multi-vehicle accident Jennifer had mentioned was taking longer to arrive than expected. Sometimes that meant the patients had been diverted to other facilities. Sometimes it meant paramedics were still working to stabilize people enough for transport. Maya used the temporary lull to review protocols on the computer. Not because she needed refreshing, but because it helped her stay current on how this particular institution approached various emergencies. Every hospital had slight variations in their procedures. Understanding those variations prevented confusion when seconds mattered. Director Wilson approached the nurses' station, ostensibly checking on department status, but his attention kept drifting to Maya. She felt his observation, but didn't react. If he'd recognized her tattoo and looked up her background, that was his choice. She wasn't going to initiate a conversation about it. "How's the shift going?" Wilson addressed the question to Jennifer, but his eyes were on Maya. "Quiet so far," Jennifer replied. "We're waiting on that Interstate 5 accident, but no ETA yet." Wilson nodded, making notes on his tablet. Then casually, almost as an afterthought, "Rodriguez, your former military, correct?" Maya looked up from the computer screen. "Yes, sir." "Army. What was your MOS?" 68 whiskey initially, then physician training." She kept her answer vague, not offering details he hadn't specifically requested. Wilson's expression didn't change, but something shifted in his eyes. Recognition. Understanding. He'd confirmed what he'd suspected. "If you need anything, my door is always open." The offer was genuine, conveyed in a tone that suggested he understood exactly who he was talking to. Maya nodded once, acknowledged but non-committal. Wilson moved on completing his rounds, but the interaction had changed something. He knew, which meant eventually others would know. The quiet anonymity she'd been maintaining for 8 months was starting to crack. Dr. Harrison was still at the nurses' station now, complaining to a resident about hospital politics. His voice carried that particular tone of someone who needed everyone to understand he'd been wronged. Maya had heard it before from officers who'd been passed over for promotion. The combination of wounded pride and desperate need for validation. She almost felt sorry for him. Almost. But sympathy was hard to maintain for someone who'd spent the evening mocking her based on assumptions and ignorance. The ambulance bay doors suddenly burst open with explosive force. The calm before had been deceptive. Now, chaos arrived all at once. Paramedics moving at controlled run radio traffic, overlapping the immediate shift from quiet to crisis that defined emergency medicine. Dr. Harrison's complaint stopped mid-sentence. His expression changed, professional focus, replacing wounded ego. Whatever his personality flaws, he was technically competent when cases demanded his attention. Maya moved toward the trauma bay doors, her body responding before conscious thought fully processed what was happening. Old habits. Good habits. The ones developed through repeated exposure to situations where milliseconds determined outcomes. What she didn't know yet was that the patient about to arrive would change everything. That the next 15 minutes would expose every assumption Dr. Harrison had made. That her carefully maintained anonymity was about to shatter in the most dramatic way possible. The trauma bay doors stood open, waiting. Maya positioned herself near the medication supply area, technically in her designated role, but close enough to observe, to assess, to intervene if necessary, though she'd spent 8 months training herself not to overstep the boundaries of her current position. The paramedics wheeled in their patient at speed. From her position, Maya caught glimpses. Male, approximately 30 years old. Obvious chest trauma. Blood pressure clearly inadequate based on his color. The specific pattern of injuries triggering recognition in her brain before she'd consciously processed all the details. She'd seen this before, not once or twice, dozens of times across 3 combat deployments, and she knew exactly what Dr. Harrison was about to miss. The lead paramedic was Rodriguez, someone Maya recognized from previous shifts. Former Marine Corps based on the bearing and the way he moved under pressure. His usual calm was absent tonight. Male, approximately 30 years old, high-speed motor vehicle accident on Interstate 5 southbound. Rodriguez rattled off details while they transferred the patient to the trauma bed. T-boned by a commercial truck at highway speed. Massive chest trauma, suspected internal bleeding. Blood pressure was 90/60, at scene dropped to 80/50 en route. Pulse is 130 and climbing. We've got 2 large-bore IVs running wide open, gave him 2 liters in the ambulance, but he's not responding. Maya moved immediately toward Trauma Bay 1. Her body was responding to patterns her conscious mind was still processing. But Dr. Harrison's hand caught her shoulder. Medication cart needs restocking. His voice was dismissive. We've got this handled. Maya's eyes tracked to the patient, then to the monitors, then back to Harrison. Every instinct screamed at her to argue. But she'd learned that civilian medicine operated under different rules than combat. Hierarchy mattered here in ways it didn't when lives hung in immediate balance and competence trumped rank. She stepped back, but she didn't leave. Something about this case was activating recognition networks built through 3 years of forward-deployed trauma surgery. The angle of the paramedic's approach. The specific pattern of chest trauma visible even from this distance. The rate of vital sign deterioration. She'd seen this before, many times. Dr. Harrison moved to the head of the trauma bed, his earlier complaints about hospital politics replaced by professional focus. He began his primary survey with practiced efficiency, calling out findings as he worked. Airway is patent. Breathing is labored, diminished breath sounds on the left side. Circulation is clearly compromised. Jennifer, I need those fluids running faster. Get me a portable chest X-ray and call the OR. Let them know we might be coming up. The trauma team assembled around the bed, each person moving into their designated role. Maya watched from her position near the supply area, hands automatically organizing medications while her eyes tracked every detail of the resuscitation unfolding 15 feet away. The patient's chest wall movement was asymmetric. Left side expansion was minimal compared to right. The bruising pattern across his sternum suggested direct steering wheel impact, but there was additional discoloration spreading laterally that indicated something beyond simple blunt force trauma. The way his neck veins were beginning to distend, the mottled quality of his skin despite aggressive fluid resuscitation. Maya's fingers traced her tattoo unconsciously. Director Wilson noticed the gesture from his position near the trauma bay entrance. He'd seen that particular tell before in combat veterans. The subconscious reaching for something familiar when training activated at levels beyond conscious awareness. Blood pressure dropping. One of the nurses called out numbers that made several team members tense. 70/45. Increase the fluid rate. Harrison's order was immediate, but Maya heard the slight edge in his voice. Uncertainty trying to hide behind authority. Push another liter of normal saline. Someone get me that chest X-ray now. Heart rate 150. Another nurse's voice climbed slightly. Oxygen saturation dropping to 88%. Maya's clinical assessment crystallized. This wasn't just chest trauma. The specific constellation of findings: high-velocity impact, steering wheel mechanism, rapid deterioration despite aggressive volume resuscitation, asymmetric breathing. The pattern was triggering memories of cases she'd managed in Afghanistan. Kandahar Province, 2021. A convoy vehicle hit by vehicle-borne improvised explosive device. The driver had been thrown forward into the steering wheel at extreme velocity. The injuries had presented exactly like this: pneumothorax, hemothorax, and the piece everyone had initially missed. Cardiac tamponade from great vessel injury. She'd lost that soldier because she'd been too slow recognizing the full pattern. By the time she'd identified the cardiac component, irreversible shock had already developed. She'd performed the pericardiocentesis anyway, hoping for a miracle that never came. His name was carved into her memory, along with 8 others she'd been unable to save. She would not let that happen again. Not here. Not when she knew exactly what she was looking at. Dr. Harrison. Maya's voice was quiet, but carried authority she usually kept carefully buried. I think you should consider the possibility of cardiac involvement. Nurse Rodriguez. Harrison didn't look up from his examination. I need you to prepare supplies, not provide medical commentary. This is a complex trauma case requiring physician-level assessment. Heart rate 160. The monitoring nurse's voice carried increased urgency. Blood pressure 60/35. Harrison's movements became faster, less controlled. Maya recognized that pattern too. A competent physician encountering something outside his experience range, compensating with speed rather than changing approach. She'd seen it in military physicians who'd never worked in true combat conditions. They knew the textbooks but hadn't developed the pattern recognition that came from repeated exposure to injuries civilian medicine rarely encountered. Get me a fast exam ultrasound. Harrison was ordering tests that would take precious time. Push another liter of fluid. Someone page cardiothoracic surgery now. More fluids wouldn't help. The problem wasn't volume depletion. Blood was accumulating where it shouldn't be. The patient's chest cavity was filling from a torn vessel, and his heart was being compressed by fluid in the pericardial sac. Standard resuscitation protocols were keeping him marginally alive, but not addressing the actual pathology killing him. Maya had seen 4 soldiers die from nearly identical injuries before she'd recognized the pattern. After that, she'd saved 13 more with the same presentation. The difference was learning to see past the obvious chest trauma to the cardiac component everyone missed because it was subtle, until suddenly it wasn't, and then it was too late. Dr. Harrison. Maya stepped closer to the bed, her voice carrying a different tone now. His neck veins are distending. Heart sounds are diminished. Combined with the mechanism of injury and refractory hypotension, despite adequate volume resuscitation, I think we need to consider Beck's triad. Cardiac tamponade. What I need, Harrison snapped, finally turning to face her directly, is for you to understand your role. This is a level 1 trauma resuscitation, not a teaching conference. If I need medication, I will ask for it. Otherwise, please step back and allow the medical professionals to work. The words landed with physical force. Around the trauma bay, several staff members visibly winced. Jennifer looked like she wanted to intervene, but didn't know how. The hierarchies were clear, and challenging them publicly required more courage than most people possessed. Director Wilson stepped forward from the doorway. Dr. Harrison, perhaps we should listen to what Nurse Rodriguez is suggesting. Director, with all due respect. Harrison's frustration was barely contained. This is an acute medical emergency requiring immediate physician intervention. I don't have time to manage personnel issues right now. The monitors erupted with urgent alarms. Blood pressure crashed to 50/20. Heart rate spiked to 190, irregular rhythm, suggesting cardiac distress beyond simple tachycardia. The electronic warnings filled the trauma bay with sound that made several team members move faster, react with greater urgency. He's crashing. Someone stated the obvious as monitors screamed their electronic panic. Maya watched Dr. Harrison's face cycle through emotions in rapid sequence. Confusion as the patient deteriorated despite everything he was trying. Fear as he realized this was spiraling beyond his control. Anger at the situation, at himself, at the universe for presenting him with something he couldn't manage. And finally, something approaching panic as standard protocols continued failing. Start CPR, Harrison ordered as the pulse disappeared from the monitor. Maya's body moved before her brain completed the decision. She was at the bedside, her hand on Harrison's arm, her voice carrying a command tone that stopped everyone in the trauma bay. Stop. The single word cut through chaos like a blade. Dr. Harrison stared at her with shock and outrage competing for dominance on his face. Nurse Rodriguez, you are completely out of line right now. This patient has Beck's triad. Maya interrupted, her eyes never leaving the monitor. Jugular venous distension, muffled heart sounds, and hypotension, despite adequate volume resuscitation. Combined with high-velocity steering wheel impact mechanism and the specific pattern of rapid deterioration, he has cardiac tamponade, likely from a great vessel tear. CPR will be completely ineffective because the problem isn't cardiac arrest. It's mechanical compression of the heart from blood accumulating in the pericardial sac. The trauma bay went silent except for the screaming monitors. Every person present was staring at Maya. Not at the quiet nurse who restocked medication carts. At someone else entirely. Someone who spoke with absolute certainty about patterns they recognized because they'd managed them before. He needs immediate pericardiocentesis. Maya's voice remained steady despite her elevated heart rate. And he needs it in the next 60 seconds or this becomes irreversible. Every moment we spend on standard ACLS protocols is allowing more blood to accumulate around in his heart. Your experience? Dr. Harrison's voice carried sharp sarcasm that didn't quite mask underlying uncertainty. What experience could a floor nurse possibly have with diagnosing cardiac tamponade? You don't make diagnostic calls, and you certainly don't determine treatment plans. Now step back before I have security remove you from this department. Director Wilson moved fully into the trauma bay, his presence commanding immediate attention. Dr. Harrison, I strongly suggest you listen to what Nurse Rodriguez is saying. Director, I appreciate your concern, but this is a medical decision, and Nurse Rodriguez is not qualified to make diagnostic determinations or recommend invasive procedures. With all respect, I need you to let me manage this case. She's more qualified than you know. Walsh's voice was quiet, but carried absolute conviction. Trust me on this. The patient's monitor showed a rhythm that was increasingly agonal. Electrical activity was present, but mechanical function was nearly absent. Seconds remained before this transitioned from critical to catastrophic to irreversible. Maya looked at Director Wilson across the dying patient's body. She saw recognition in his eyes, understanding. He'd figured out who she actually was, what she was actually capable of. And now he was giving her permission to step out of the shadows she'd been hiding in for 8 months. Dr. Harrison. Maya's voice dropped lower, carried weight that came from having made life and death decisions under conditions most people couldn't imagine. I have seen this exact injury pattern 47 times across 3 combat deployments. I have performed emergency pericardiocentesis under mortar fire in transport vehicles, moving at speed, and in field hospitals with no backup and minimal equipment. This patient presents with the identical findings I encountered in vehicle-borne IED blast victims in Helmand Province. She paused, making eye contact with Harrison directly. If we don't decompress his pericardium in the next 60 seconds, he dies. Those are not opinions. Those are facts based on extensive experience with this specific pathology. Harrison stared at her. His brain was clearly struggling to process new information against assumptions he'd built about who Maya Rodriguez was. 47 times. He repeated the number like he couldn't quite believe it. 47. Maya's hand moved to her tattoo, and for the first time since arriving at this hospital, she didn't try to hide it, didn't minimize it. This isn't random military ink, Dr. Harrison. This is the designation for Special Operations Medical Leadership. I spent 18 months as Senior Trauma Surgeon for Special Operations Task Force 31 in Afghanistan. I have performed more emergency procedures under direct combat conditions than most civilian surgeons will see in their entire careers. The words hung in the air. Around the trauma bay, staff members stared with expressions ranging from shock to something approaching awe. Jennifer's mouth was literally open. The respiratory therapist had stopped what he was doing mid-action. I know you don't know me. Maya's voice softened slightly but maintained its core of absolute certainty. And I know the hierarchy here operates differently than what I'm accustomed to. But I also know this patient is dying right now. And I know exactly how to save him. So you can either let me help, or you can watch him die while you debate my credentials. Your choice. But choose fast because we're out of time. The monitor showed a rhythm that was barely compatible with life. Electrical activity without effective mechanical function. The medical term was pulseless electrical activity. The practical term was dying. Dr. Harrison looked at Director Wilson, who nodded once. A clear gesture of support and authorization. Fine. Harrison stepped back, his voice rough with emotion he was trying to control. Show me what you know. Maya moved to the patient's right side, her hands already palpating for anatomical landmarks through his chest wall. I need an 18-gauge needle at least 4 inches long. Sterile prep solution. 10 cc syringe. And everyone needs to be ready because when I remove blood from his pericardium, his pressure will improve rapidly. Which means we need to be prepared for whatever else is bleeding to become more apparent. Jennifer moved with practiced efficiency assembling supplies on the sterile tray. Maya's hands worked automatically prepping the site while her mind calculated angles and depths. This was muscle memory developed through dozens of procedures performed in conditions ranging from well-lit operating rooms to caves illuminated only by headlamps. The landmarks are identical, regardless of whether you're in a state-of-the-art trauma center or a forward operating base in Kandahar province. Maya narrated for the team's benefit. You're targeting a point 1 centimeter inferior to the xiphoid process, angled 45 degrees toward the left shoulder. The pericardial space is typically 4 to 6 centimeters deep in an adult male. With active hemorrhage, you'll encounter it sooner. Her hands moved with confidence that only came from extensive experience. The needle advanced through tissue Maya's proprioception, giving her feedback about what she was encountering. Skin resistance, subcutaneous tissue. The slight increase in resistance as the needle passed through muscle layers. You'll feel a distinct pop when you penetrate the pericardium. Maya continued her narrative. And then pressure will equalize and you'll get blood return. Non-clotting blood because it's been sitting in the pericardial sac long enough to defibrinate. The needle advanced another centimeter. Maya felt the characteristic pop of penetrating the fibrous pericardial membrane. There, she said softly, holding position with absolute steadiness. 20 cc's of dark, non-clotting blood. That's your diagnostic confirmation of hemorrhagic cardiac tamponade. She aspirated slowly, removing blood that had been compressing the heart and preventing effective filling during diastole. On the monitor above the bed, the effect was nearly instantaneous and dramatic. Blood pressure rose from 50 to 70, then to 90, then to 100/60. Heart rate dropped from 190 to 160, then to 130, then to 100. The patient's skin color improved from grayish blue to pale pink in seconds. Around the trauma bay, the entire team seemed to collectively exhale. The electronic alarms quieted as vital signs stabilized. The chaos that had dominated moments before transformed into organized, purposeful activity. He's still actively bleeding somewhere. Maya withdrew the needle carefully, maintaining her focus. The tamponade was compressing the heart, which limited cardiac output. That actually helped control the hemorrhage to some degree by reducing perfusion pressure. Now that we've decompressed the pericardium, his blood pressure is better, but whatever vessel is torn is going to bleed more aggressively. He needs an operating room immediately. Most likely scenario is a torn branch of the aorta or a great vessel injury requiring surgical repair. Dr. Harrison stood motionless, watching monitors display a patient who had been seconds from death, now showing stable vital signs. His expression was difficult to read. Shock and embarrassment and something that might have been respect were all competing for space on his face. Someone call the OR. Director Wilson's voice carried calm authority. Tell them we have a penetrating great vessel injury requiring immediate surgical intervention. Get their best cardiovascular surgeon ready now. The trauma team mobilized with renewed purpose around the stabilized patient. Maya stepped back from the bed, her hands steady during the procedure, but beginning to show slight tremor now as adrenaline faded. She'd performed this exact intervention dozens of times in Afghanistan, but never in a civilian hospital where everyone would be watching, questioning, evaluating every move. Dr. Harrison approached her slowly. His earlier arrogance was completely absent. That was. He started, then stopped, apparently unable to find adequate words. How did you know? How did you read that so fast? Because I've seen good soldiers die from this exact injury pattern. Maya looked down at her forearm at the tattoo Dr. Harrison had mocked less than 30 minutes earlier. And I learned to recognize it quickly enough to save the ones who came after them. That's what this so-called ridiculous tattoo means, Dr. Harrison. It means I've earned the right to speak up when I know I can help save someone's life. The trauma bay doors opened as the OR team arrived to transport the patient to surgery. As they wheeled him toward the elevators, the patient was breathing more easily, his color continuing to improve, vital signs holding stable. A life saved, because someone had recognized a pattern others missed. Maya caught Director Wilson's eye across the trauma bay. He nodded once, a gesture that conveyed respect, understanding, and acknowledgement that her carefully maintained anonymity was now completely shattered. The quiet nurse with the ridiculous tattoo had just performed a procedure that demonstrated expertise beyond what most of the hospital's staff possessed. There would be questions now, conversations, scrutiny. The comfortable obscurity she'd maintained for 8 months was gone, burned away in 15 minutes of controlled crisis that had required her to reveal exactly who she actually was. Dr. Harrison stood near the trauma bay doorway, watching the OR team disappear down the hallway with their patient. His hands were shaking slightly. Maya recognized post-crisis physiological response. The adrenaline surge that sustained you through emergency, now fading and leaving tremors and fatigue in its wake. Jennifer approached Maya quietly, her expression a mixture of awe and confusion. "How long have you been able to do that? How much else don't we know about you?" Maya didn't have a good answer. The truth was complicated. She was a decorated combat surgeon working as a floor nurse because civilian credentialing systems didn't know how to process military medical experience. She had capabilities far beyond her current role, but had been trying to navigate bureaucracy quietly rather than making waves. She'd spent 8 months attempting to blend in, and now that strategy had exploded spectacularly. Director Wilson was making notes on his tablet, but his attention kept returning to Maya. She could see him processing implications, considering options, calculating how to handle a situation that was unprecedented in his experience. A nurse had just performed an invasive procedure that saved a patient's life. Protocol said that shouldn't have happened. Reality said it absolutely needed to happen, and everyone present knew it. The trauma bay was quieting now. The crisis had passed. Staff members were cleaning up, restocking supplies, returning the space to ready status for whatever came next. But the energy had fundamentally changed. People kept glancing at Maya, with expressions that ranged from newfound respect to curiosity to something approaching disbelief. She'd proven her competence in the most dramatic way possible. But she'd also created complications that would take time to resolve. Questions about scope of practice, liability, credentialing, authority. All the bureaucratic concerns that civilian medicine prioritized in ways combat medicine never could afford to. Maya returned to the medication cart, falling back into routine tasks because they were familiar and controllable. Her hands organized supplies while her mind processed what had just happened. She'd saved a life. That was what mattered most. But she'd also irrevocably changed her situation here in ways she couldn't fully predict yet. Dr. Harrison was walking toward her. His posture had changed completely from earlier in the shift. The arrogance was gone. What remained was someone genuinely shaken by how close they'd come to losing a patient because of their own limitations. The real question was what would happen next. The trauma bay had that particular stillness that always followed controlled chaos. Blood-stained gauze littered the floor around the disposal bins. Used syringes filled the sharps container to near capacity. The monitors, now disconnected from their patient, displayed flat lines that would have been alarming minutes earlier, but were now simply neutral absence of data. Maya stood at the sink, scrubbing her hands with thoroughness that military training had made automatic. The water ran pink, then clear. Her hands moved through the familiar ritual. Soap, rinse, repeat. While her mind processed everything that had just happened in ways she wasn't entirely ready to confront yet. She'd exposed herself. Everything she'd been trying to keep quiet for 8 months. Everything she'd been attempting to navigate through proper credentialing channels without drawing attention. All of it had just been revealed in front of half the night shift emergency department staff in the most dramatic way possible. Maya. Director Wilson's voice was gentle, but carried unmistakable authority. She turned to find him standing in the trauma bay doorway, his expression thoughtful and unreadable. "My office, now please." The walk through the emergency department to Wilson's administrative office felt longer than the actual distance warranted. Staff members watched her pass, some with curiosity, some with newfound respect. a few with expressions she couldn't quite interpret. The comfortable anonymity she'd maintained for 8 months was completely gone now, burned away in 15 minutes of crisis that had required her to reveal capabilities she'd been carefully hiding. Wilson's office was modest for a hospital director. Military commendations occupied one wall. Medical certifications and administrative awards covered another. Family photos arranged on his desk showed children and grandchildren at various ages. Sarah noticed a combat deployment photo from what looked like Iraq. Wilson in Army combat uniform, standing in front of what was clearly a combat support hospital. The visual context explained how he'd recognized her tattoo so quickly. "Sit." Wilson gestured to a chair across from his desk. Maya remained standing. Old habits from 12 years in uniform. You didn't sit in a superior officer's office unless explicitly ordered. The posture was automatic muscle memory from thousands of similar interactions. Wilson noticed, and a slight smile crossed his face. "At ease, Lieutenant Colonel. This isn't a formal counseling session. You're not in trouble." The use of her military rank made Maya's spine straighten reflexively despite his reassurance. "You looked me up. I recognized your tattoo the moment I saw it properly tonight." Wilson settled into his own chair, gesturing again for Maya to sit. She did this time, though her posture remained military straight. "I spent 22 years in Army medicine, including 4 years as Deputy Commander of Medical Command. I've only seen 4 people wearing that particular combination of symbols in my entire career. Each one was someone I'd want in the trauma bay if my life was on the line." Maya finally sat, but her posture remained alert. "Then you know I'm trying to navigate the civilian credentialing process. I didn't mean to overstep tonight, but when I saw that patient, I couldn't just watch him die. When I knew exactly what was wrong and how to fix it. But you saved his life." Wilson's interruption was firm, brooking no argument. "Dr. Harrison is a good surgeon, well-trained, technically competent, excellent academic credentials. But he's never encountered that specific injury pattern because civilian medicine rarely sees it outside of high-velocity trauma. You recognized it immediately because you've treated it before." "Many times, apparently." 47. Maya confirmed quietly. Vehicle-borne, improvised explosive devices create a specific blast pattern. The driver gets thrown forward into the steering wheel at extreme velocity, creates chest trauma that initially looks like standard motor vehicle accident injuries. But the kinetic force is different, more concentrated. It causes cardiac and great vessel injuries that typical civilian accidents don't produce with the same frequency. Wilson leaned forward, genuine interest evident in his expression. "How many of those 47 did you save?" Maya's hands tightened slightly in her lap. 38. 80% survival rate for one of the most lethal injury patterns in combat medicine. Wilson let that statistic hang in the air between them. "Do you know what the survival rate was before specialized combat surgeons like you developed recognition protocols and treatment algorithms? Less than 30%. You and others like you literally rewrote the textbook on battlefield trauma care during 2 decades of conflict. We did what we had to do." Maya's voice flattened the way it always did when discussing casualty statistics. 9 soldiers still died under my care, and 38 went home to their families because you knew what to look for and how to treat it fast enough." Wilson's response was immediate and carried conviction. "That's not failure, Lieutenant Colonel. That's expertise earned under the absolute worst possible conditions." The office fell quiet for a moment. Through the window, Maya could see the emergency department continuing its nocturnal rhythm. Life and death, crisis and recovery. The endless cycle of emergency medicine playing out in real time just beyond the glass. "Why are you working as a floor nurse?" Wilson finally asked the question Maya had been dreading since this conversation started. "And please don't tell me it's by choice, because we both know that's not true." Maya exhaled slowly. "The credentialing process for military physicians transitioning to civilian practice is Byzantine in its complexity. My medical degree from Uniformed Services University is recognized, but my residency training was completed under combat conditions. Civilian medical boards want documentation of procedures performed, supervision records, evaluation forms. The kind of paperwork that doesn't exist when you're performing thoracotomy in a cave with nothing but a headlamp, while indirect fire is impacting within 100 meters of your position. So they're making you start over. Essentially, Maya couldn't keep frustration from leaking into her voice, despite attempts at professional neutrality. I'm working as a nurse while I navigate appeals processes and try to document 3 tours worth of medical experience in formats that satisfy state licensing boards who have never encountered someone with my background. They want proof I can perform procedures I've done hundreds of times. They want supervision documentation from attending physicians who were often thousands of miles away, while I was the senior medical officer for an entire task force. The system isn't designed for people like me. Wilson was quiet for a long moment, his fingers steepled in front of his face in an expression Maya recognized from commanding officers, making decisions that would affect people's careers and lives. I might be able to help with that, Wilson said finally. I still have connections in military medicine and with some state medical boards through my work with veteran physician transitions. But Maya, I need to know something first. Do you want to practice medicine here? At this hospital, because what happened tonight can't become your default operating mode. You can't be a floor nurse who sometimes performs advanced procedures when emergencies demand it. That's a liability nightmare for the institution and profoundly unfair to you personally. I want to practice medicine. Maya's response was immediate and carried absolute certainty. I spent 12 years training to be a trauma surgeon. I've used those skills in conditions most people can't imagine and wouldn't believe if I described them. I'm good at what I do, Director Wilson. But I also understand that civilian medicine has different rules and different hierarchies than what I'm accustomed to. I won't circumvent proper channels again, even if it means watching a patient die when you know you could save them. The question exposed the central tension Maya had been wrestling with for 8 months. Civilian medicine prioritized protocol, credentialing, liability protection. Combat medicine prioritized one thing above all else: keeping people alive by any means necessary, using any skills available. I don't know, Maya admitted after a long pause. Tonight, I couldn't watch that patient die when I knew exactly what was wrong and exactly how to fix it. But I also know that's not sustainable long-term. Either I need to be properly credentialed to practice at my actual capability level, or I need to accept my current role and stay within its boundaries. Wilson nodded slowly, processing her answer. Let me make some calls. I can't promise anything happens quickly because bureaucracy moves at its own glacial pace, regardless of how many favors you call in. But I can probably accelerate your credentialing review, especially with tonight's case, as concrete documentation of your capabilities under pressure. In the meantime, how would you feel about being listed as a trauma consultant for the emergency department? It's not a formal staff position, but it gives you some legitimacy to provide input on cases and participate in resuscitation efforts when your expertise could make a difference. Dr. Harrison has agreed to supervise and document your work, which should provide additional evidence the medical board needs for their review. Maya felt tears prick at her eyes and blinked them back firmly. She'd spent 8 months feeling like her experience was being dismissed, like skills she'd developed through repeated exposure to the worst trauma imaginable were worthless in the civilian world. Like the soldiers who died teaching her hard lessons had died for nothing if she couldn't use what she'd learned to help others. Thank you. Her voice was quiet but steady. I don't know what you said or who you called, but thank you for believing my experience has value. I told them the truth, Wilson replied simply, that you're one of the most skilled trauma specialists I've encountered in 40 years of military and civilian medicine combined. That making you restock medication carts is a criminal waste of expertise this institution and this community desperately needs. The rest was just navigating bureaucracy and knowing which levers to pull in which order. They sat in comfortable silence for a moment, the weight of the conversation settling between them. Outside the window, an ambulance pulled into the bay, its lights painting red and white patterns across the parking area. More patients arriving, more crises to manage. The work never stopped in emergency medicine. "How are you doing?" Wilson asked, shifting the conversation. "Really doing. Because I know the transition from military to civilian medicine is challenging, and without credentialing complications, and even for people who didn't spend 3 years in combat zones." Maya considered deflecting with the easy answer, the automatic fine that had become her default response to that question over 8 months. But Wilson had been military. He'd deployed. He would understand things civilian colleagues couldn't. "Some days are harder than others," she admitted carefully. "The pace here is different. Slower in some ways because you have time to think and consult. Faster in other ways because the volume is relentless. People take breaks, have personal conversations during shifts, treat medicine like a job with boundaries rather than a mission that consumes everything. It's not wrong, just profoundly different from what I'm used to. And the trauma, not the physical injuries you treat. The trauma you're carrying from 3 years downrange." Maya's hand moved unconsciously to her tattoo. "I still have nightmares about the ones I lost. Still hear their voices sometimes when I'm trying to sleep. I still do threat assessments automatically every time I enter a room. Still flinch at unexpected loud noises. The other day, someone dropped a metal instrument tray, and I was on the floor behind the nurse's station before I consciously processed what the sound was. But I'm managing most days." "Are you seeing someone professional help?" "VA provided therapy when I first separated. It helped to an extent, but a lot of what I'm dealing with isn't PTSD in the traditional clinical sense. It's more." Maya struggled to articulate something she'd been thinking about for months without finding adequate words. "It's grief and loss of purpose. I spent 12 years doing work that mattered in the most immediate, visceral way possible. Every procedure I performed, every decision I made had direct life or death consequences I could see in real time. Coming to civilian medicine, where most of the day is routine, where you have time to consult with colleagues and follow established protocols, where most patients survive regardless of what you do. It's good medicine, but it lacks the intensity I built my entire identity around." Wilson nodded slowly, understanding evident in his expression. "I felt something similar when I retired from military service, like I was operating at half speed all the time, like nothing quite mattered the way it used to, like I'd lost the thing that made me who I was." "How did you adjust? What made it bearable?" "I found new purpose. For me, it was administration. Using my experience to improve systems and processes rather than individual patient outcomes. Making changes that would help hundreds of people I'd never meet, rather than saving individual lives I could see. For you, maybe it's teaching. You took what you know from combat medicine, and you just used it to save a life here. But more than that, you showed Dr. Harrison and everyone else in that trauma bay something they'd never seen before. That has value beyond this one patient." Maya hadn't thought about it that way. She'd been so focused on getting credentialed to practice medicine at her actual level that she hadn't recognized potential value in what she was already doing, even within her current constraints. The teaching aspect could be formalized. Wilson continued clearly thinking through possibilities in real time. "We could develop a training program. Military-derived trauma protocols integrated into civilian emergency medicine. You could lead it. Share what you know with physicians who will never deploy, but could benefit from combat-tested approaches to high-acuity trauma and mass casualty situations." The idea took root in Maya's mind immediately. A way to use her experience that didn't require waiting months for credentialing approvals. A way to honor the soldiers she'd lost by ensuring their deaths taught lessons that would save other lives. A way to find purpose in transition rather than just waiting for permission to return to work she'd been doing for years. "I'd need to think about curriculum design." Maya was already mentally sketching possibilities. Case-based learning, pattern recognition training, Hands-on simulation for procedures civilian physicians rarely perform. It could work if we structured it properly. Work up a proposal. Wilson's tone suggested he was already committed to the idea. Detailed outline, resource requirements, potential measurable outcomes we can show to hospital administration. If we can demonstrate value, and I believe we absolutely can, we might secure funding to make this a formal program. Maya felt something she hadn't experienced in months. Genuine excitement about the future, rather than just anxiety about navigating bureaucratic obstacles. This could be more than solving her own credentialing problems. This could create a pipeline for other veterans struggling with similar transitions. This could actually change things. I'll have something for you within a week, she promised. Good. Wilson stood signaling the meeting was concluding. But Maya, one more thing. What you did tonight took courage. Speaking up when everyone was telling you to be quiet. Challenging hierarchy when a life was at stake. That's exactly the kind of judgment and moral courage that earned you that tattoo. Don't lose that just because you're not in uniform anymore. The words settled over Maya like a weight and a gift simultaneously. She'd spent 8 months trying to blend in, trying not to cause problems, trying to navigate systems quietly. And tonight she'd done the opposite because someone was dying and she knew how to help. Wilson was telling her that was exactly right. Now I believe Dr. Harrison is waiting outside. Wilson moved toward his office door. I think he'd like to speak with you if you're willing. Maya followed Wilson out of the office and found Dr. Harrison standing in the hallway near the emergency department break room. His usual confident posture was absent. He looked smaller, somehow, diminished in ways that had nothing to do with physical stature. When Maya emerged from Wilson's office, Harrison straightened slightly, but didn't approach immediately. The dynamic between them had fundamentally changed in the past hour, and both of them were still processing what that meant. Maya almost walked past him. Documentation waited. Charts needed completing. The emergency department would continue its rhythm regardless of personal conversations. But something about Harrison's body language made her pause. This wasn't the arrogant surgeon from earlier in the shift. This was someone genuinely struggling with something. Dr. Harrison, I owe you an apology. The words came quickly like he'd been rehearsing them. Multiple apologies, actually. For mocking your tattoo without understanding what it meant. For dismissing your clinical assessment based on assumptions about your role. For letting my ego and insecurity nearly cost a patient his life. Maya studied him carefully. She'd learned in combat to evaluate whether someone's contrition was genuine or tactical, whether they were sorry for their actions or just sorry. They'd been caught and exposed. Harrison's discomfort appeared authentic. The kind of embarrassment that came from having your competence legitimately challenged and being forced to confront limitations you didn't know you had. Apology accepted, Maya said simply. That's it. Harrison looked surprised. You're not going to tell me everything I did wrong. Explain all the ways I failed that patient. Would it help? The question seemed to catch Harrison off guard. I don't know. Maybe. Maya gestured to a quiet corner of the hallway, away from the main flow of emergency department traffic. They sat in uncomfortable plastic chairs that all hospitals seemed to favor, the kind designed to discourage lingering. Dr. Harrison, can I ask you something? Maya kept her voice neutral and non-judgmental. Have you ever felt genuinely overwhelmed by a medical case? Not just busy or stressed, truly in over your head, where nothing you tried was working and you couldn't figure out why. Harrison was quiet for a long moment. Tonight, he finally admitted. When that patient started crashing and nothing in my standard approach was effective, I knew something was wrong beyond routine trauma, but I couldn't identify what. And the more I tried, the worse he got. I felt completely helpless while watching someone die. That's what combat medicine is like constantly, Maya said softly. Every case is someone in extremis. Resources are limited or non-existent. Backup is hours away if it exists at all. You learn to recognize patterns incredibly quickly because any delay means death. You learn to act decisively because hesitation produces the same result as wrong action. How do you develop that kind of instinct? Harrison struggled for adequate words. That immediate pattern recognition. You don't want the real answer to that question. Why not? Because the real answer is that you develop it by watching people die. Maya's voice carried weight of memory and loss. Every soldier I lost taught me something. Every mistake I made got written in someone else's blood. The pattern recognition you saw me use tonight came from 9 soldiers who died from cardiac tamponade before I learned to identify it fast enough to save them. The confidence in my procedure technique came from dozens of attempts in terrible conditions, where failure meant someone's family received a flag and a folded uniform instead of their loved one coming home. The brutal honesty of that statement settled over them. In the background, the emergency department continued its constant activity. Ambulance sirens approaching and receding. Overhead pages calling for consultations. Monitor alarms providing electronic soundtrack to human crisis. I can't teach you what I know completely. Maya continued after letting her words sink in. Not fully. Because what I know came from context you haven't experienced and hopefully never will. But I can teach you to recognize the patterns. To know what questions to ask. To understand when standard protocols aren't enough and you need to think differently. Harrison looked up sharply. You'd be willing to teach me? After how I treated you tonight, you made assumptions based on incomplete information. That's human nature. What matters is what you do with correct information once you have it. Maya paused. Besides, that patient survived because we worked together, however awkwardly. You had the resources and the authority. I had the specific expertise. That's how it's supposed to work when egos don't get in the way. Director Wilson mentioned something about you getting credentialed as a trauma surgeon. Eventually, maybe, if I can successfully navigate the bureaucratic maze. Maya's frustration leaked through again. Turns out that performed emergency thoracotomy in a cave under enemy fire doesn't translate easily into standard residency documentation formats that licensing boards understand. Harrison was quiet for a moment, clearly thinking, what if I helped? How? I'm not on the medical board, but I have connections. And more importantly, I can document your clinical competence directly. If you're willing to work with me informally while your credentials are being processed, I could provide detailed attestations of your capabilities. Specific cases, procedures performed, clinical judgment demonstrated. It might help accelerate the review process. Maya considered this carefully. It was the first concrete offer of help she'd received from anyone in the civilian medical world, beyond vague promises to look into things. Why would you do that? Because I almost let a patient die tonight due to my own ignorance and arrogance. Harrison's voice was blunt with self-assessment. And because someone with your level of expertise shouldn't be wasted restocking medication carts while you wait for bureaucrats to process paperwork. That's not false modesty or performative humility. It's just observable reality. Okay, Maya said after a moment of evaluation. Let's see what we can accomplish together. They stood simultaneously, an awkward moment of figuring out how to conclude this conversation appropriately. Harrison extended his hand and Maya shook it. A formal gesture that somehow felt right for the occasion. One more thing, Harrison said as they prepared to return to their respective duties. That tattoo, what does it actually mean? The specific symbols, I mean. Maya glanced down at her forearm, the design that had caused so much conflict earlier in the shift. The eagle represents Special Operations Command. The 5 stars mark 5 high-risk missions successfully completed under combat conditions. The medical cross integrated into the wings designates completion of Special Operations Medical Leadership Course, a training program with approximately 50% attrition rate that produces the military's most advanced combat medical providers. She traced the design with one finger, the gesture that had become habitual over years. But the real meaning isn't about the symbols themselves. It means I've earned the right to speak up when I know I can help save someone's life. Even if it means challenging authority or breaking protocol. Because when lives hang in the balance, competence matters more than hierarchy or credentials or institutional politics. Harrison nodded slowly, processing this. I wish I'd understood that before I started mocking it. Now you do, Maya said simply. And now, every time you see it, you'll remember that appearances can be deceiving and assumptions can be dangerous. Maybe that's the lesson that needed teaching tonight. As they walked back into the emergency department together, Maya felt something fundamental shift. Not everything. Her credentialing issues remained unresolved. The transition to civilian life was still challenging. She'd probably created complications by revealing her background so dramatically. But for the first time in 8 months, she felt like maybe she'd found allies. People who understood what she was capable of and wanted to help rather than just process her through bureaucratic systems designed for typical transitions. The trauma bay doors stood ready for whatever arrived next. Maya returned to her duties, completing documentation from the case that had changed everything. Her hands moved through familiar tasks, while her mind processed possibilities she hadn't allowed herself to consider before. Director Wilson had suggested teaching. Dr. Harrison had offered to help with credentialing documentation. Together, those two things might create a path forward that didn't require waiting months for bureaucratic approval. Maya touched her tattoo one more time, not hiding it, not ashamed of it, acknowledging what it represented about her past and what it might enable for her future. The ridiculous tattoo that Dr. Harrison had mocked. The symbols Director Wilson had immediately recognized. The design that told a story of expertise earned through the hardest possible lessons. It was still the same tattoo, but everything else was beginning to change. And maybe Maya thought as she watched the emergency department continue its endless cycle of crisis and recovery, that was exactly how transformation happened. Not through grand gestures, but through small moments of recognition and connection that accumulated into something larger. The night shift continued. More patients would arrive. More crises would demand attention. But now Maya faced them with something she hadn't had before: hope. 2 weeks later, the conference room on Seattle Grace's 3rd floor had been transformed into a makeshift classroom. 16 emergency medicine physicians, trauma surgeons, and senior nurses filled the seats arranged in a semicircle. Their attention focused on Maya Rodriguez as she stood at the front, beside a large projection screen, a wireless presenter remote in her hand. This was her 3rd teaching session. The first had been awkward. Maya was accustomed to briefing soldiers before missions, not lecturing civilian medical professionals in climate-controlled conference rooms. The second session had gone better, as she'd found her rhythm. This one felt almost natural, like she'd discovered a language that bridged military and civilian medical cultures. Combat trauma patterns differ from civilian injuries in predictable ways. Maya advanced to the next slide, showing comparative injury data. It's not that the anatomy changes, or that fundamental principles of trauma care are different. It's that the mechanism of injury creates specific signatures. Once you learn to recognize them, you can diagnose faster and intervene more precisely. Dr. Harrison sat in the front row, taking notes with the focused attention of a medical student rather than a senior attending surgeon. His transformation over the past 2 weeks had been remarkable. The arrogance that had defined him before had been replaced by something more valuable. Intellectual humility combined with genuine curiosity about what he didn't know. Let's examine the case from 2 weeks ago. Maya pulled up imaging studies from the patient she'd saved. This is a 45-degree chest radiograph showing the cardiac silhouette. What strikes you as significant? The cardiac shadow is enlarged. One of the attending physicians offered. Bigger than expected relative to the thoracic cavity. Exactly. Maya clicked to a closer view. But here's the critical thinking I want you to develop. In a high-velocity motor vehicle accident with steering wheel impact mechanism, you should immediately be suspicious of this finding. In routine civilian medicine, an enlarged cardiac silhouette might suggest heart failure or chronic pericardial effusion. But in high kinetic energy trauma, especially with direct anterior chest impact, this should trigger immediate concern for hemorrhagic cardiac tamponade. She advanced to the next image showing ultrasound findings from the emergency pericardiocentesis. Fast exam is standard protocol in trauma evaluation now. But how many of you would specifically examine the pericardium in a motor vehicle accident patient who's responding poorly to fluid resuscitation? Several hands rose, but not as many as Maya would have preferred. The honest response was actually encouraging, though. It meant people were genuinely assessing their knowledge gaps rather than pretending competence they didn't possess. There's no shame in not knowing something you haven't been taught. Maya's tone was supportive rather than judgmental. Military medicine learned these patterns through brutal repetition. We encountered specific injury types frequently enough that recognition became automatic. What I'm offering you is the ability to learn from our experience without requiring the same volume of casualties to develop the expertise. She walked through several more slides, each showing different aspects of combat trauma care and direct translation to civilian emergency medicine. The presentation was deliberately practical, focused on pattern recognition and clinical decision trees rather than abstract theory that wouldn't help in actual resuscitations. The fundamental principle, Maya emphasized, is systematic thinking under extreme pressure. Combat medicine forces rapid assessment protocols because detailed workups often aren't possible. You learn to ask the right questions in sequence. What's most likely to kill this patient in the next 5 minutes? What do I need to rule out immediately? What interventions can I start now while gathering more information? Dr. Harrison raised his hand. Can you walk us through your actual thought process from that night, the specific decision tree you followed? Maya nodded and pulled up a timeline she'd prepared, showing her clinical reasoning in real time. When the patient arrived at 02:47 hours, I immediately noted several key indicators within the first 60 seconds. Asymmetric chest wall movement suggesting pneumothorax or hemothorax. Specific bruising pattern consistent with steering wheel impact. Vital signs showing poor response to aggressive fluid resuscitation. That combination triggered pattern recognition from similar cases I'd managed in theater. She pointed to specific decision points on the timeline. When Dr. Harrison documented diminished breath sounds on the left at 02:49, that confirmed likely pneumothorax or hemothorax. But the diagnostic moment came at 02:52, when I observed jugular venous distension combined with muffled heart sounds and continued hypotension despite adequate volume replacement. That constellation of findings is Beck's triad, the classic presentation of cardiac tamponade. But you mentioned great vessel injury. One of the trauma surgeons interjected. How did you differentiate that from simple pericardial fluid accumulation from the chest trauma? Rate of deterioration. Maya explained. Simple pneumothorax or hemothorax causes respiratory compromise, but usually produces more gradual hemodynamic decline. This patient crashed rapidly, which suggested active arterial bleeding into a confined space, either the pericardium or chest cavity. The neck vein distension pointed specifically to pericardial involvement rather than simple thoracic hemorrhage. She could see understanding developing across multiple faces. These were intelligent, well-trained physicians. They simply hadn't encountered this specific pattern frequently enough for automatic recognition. Military medicine's hard-won experience could fill that gap. The other critical factor was mechanism of injury. Maya continued. High-velocity direct anterior chest impact can cause aortic or great vessel tears. Military medicine sees this regularly with vehicle-borne improvised explosive devices. The blast wave plus the driver being thrown into the steering wheel creates this exact injury pattern. Civilian medicine might encounter it in high-speed accidents, but it's rare enough that many emergency physicians never see it during their entire careers. That's why sharing these patterns matters. You can benefit from our experience without requiring the same volume of casualties to develop the expertise yourselves. The session continued for another 40 minutes. Maya fielded questions and walked through additional case studies. By the end, she felt energized rather than drained. This was different from combat medicine, but it was still fundamentally about saving lives. Still about using hard-won expertise to help people. As physicians filed out of the conference room, several stopped to thank Maya personally. The respect in their voices was genuine, earned through demonstrated competence rather than credentials or institutional hierarchy. Jennifer Park caught up with Maya near the door. That was incredible. I've worked in emergency medicine for 12 years, and I learned more in the past hour than in most formal conferences I've attended. Maya smiled, accepting the compliment while deflecting slightly. I'm just sharing what I learned from people who taught me through circumstances none of us would have chosen. Still, Jennifer's expression was serious. What you're doing matters. You're changing how people think about trauma assessment. Director Wilson found Maya in the emergency department staff lounge 20 minutes later. She was reviewing notes for her next teaching session, coffee growing cold beside her laptop. The fatigue of working double duty showed around her eyes. Regular nursing shifts, plus these educational sessions, plus navigating credentialing bureaucracy. The cumulative exhaustion was building. "Got a minute?" Wilson asked. Maya gestured to the empty chair across from her. The lounge was quiet at this hour, during the lull between shift changes. "I have news about your credentialing," Wilson said without preamble. Good news, mostly. Maya set down her pen, giving Wilson her complete attention. The mostly qualifier concerned her, but she waited for details before reacting. "I called in favors with the state medical board. They've agreed to review your case with a special panel that includes physicians with military medicine backgrounds. They'll evaluate your combat experience as equivalent to civilian residency training for board certification purposes." Hope surged in Maya's chest, immediately tempered by learned caution. She'd been disappointed by bureaucratic promises before. "What's the complication?" "The review process will take another 3 months minimum. They want detailed documentation of procedures you performed, which I know is challenging, given the operational security constraints of your deployments. They'll also require you to pass standard board examinations, though I suspect that won't present difficulties for you." 3 months, Maya repeated. "That's actually faster than I expected, honestly." "There's more," Wilson continued. "In the interim, I've arranged for you to be listed as a trauma consultant for the emergency department. It's not a formal attending position, but it gives you authority to provide clinical input on cases and participate in resuscitation efforts. Dr. Harrison has agreed to supervise and document your work, which should provide additional evidence the board needs for their review." Maya felt tears threatening and blinked them back firmly. 8 months of feeling like her experience was dismissed, like skills developed under impossible conditions were worthless in the civilian world. Like the soldiers she'd lost, had died without their deaths, teaching lessons that could save other lives. "Thank you." Her voice was quiet, but steady. "I don't know what you said or who you called, but thank you for believing my experience has value." "I told them the truth," Wilson replied, simply. "That you're one of the most skilled trauma specialists I've encountered in 4 decades of military and civilian medicine. That using you to restock medication carts is criminal waste of expertise. The rest was just navigating bureaucracy and knowing which people to contact in which sequence." They sat in comfortable silence for a moment. Through the lounge window, Maya could see the emergency department continuing its constant rhythm. The work never stopped. People kept having emergencies regardless of administrative conversations or credentialing reviews. "How are you doing?" Wilson asked, shifting the conversation. "Really doing. Because I know teaching plus full nursing shifts plus credentialing stress is a heavy load. Some days I'm not sure I'm managing it well," Maya admitted. "But the teaching gives me purpose beyond just waiting for bureaucratic approval. When I'm standing in front of those physicians, sharing what I learned in Afghanistan, I feel like maybe all those terrible experiences weren't completely wasted. Like maybe the soldiers I lost taught me things that can still save lives here." Wilson nodded slowly. "About that, I've been thinking about your teaching sessions and the response they're generating. Have you considered formalizing this into an actual program?" Maya looked up sharply. "What do you mean? A structured curriculum?" Wilson was clearly thinking through possibilities as he spoke. "Combat Trauma Integration Program, or something similar. Formal training that takes military-derived protocols and adapts them systematically for civilian emergency medicine. You could develop standardized modules, hands-on simulation training, case-based learning, pattern recognition workshops. The idea resonated immediately with something Maya had been thinking about without fully articulating. A way to transform her combat experience into lasting institutional change rather than just individual teaching moments. We could expand it beyond just Seattle Grace. Maya's mind was already racing through implications. Other Level 1 trauma centers face the same gaps in combat trauma knowledge. We could create a regional program, maybe even national if we prove the concept works. Exactly. Wilson leaned forward, enthusiasm evident. And here's the other piece. We could build a fellowship program for military veterans transitioning to civilian medicine. Many of them face the same credentialing challenges you're experiencing. We could create structured pathways that value their experience while helping them navigate civilian bureaucracy. Maya felt excitement building for the first time in months. Not just about her own situation, but about creating something that could help dozens or hundreds of veterans struggling with similar transitions. This could actually change things, she said slowly. Not just for me, but systematically. A bridge between military and civilian medicine that currently doesn't exist in any formal way. Write me a proposal. Wilson's tone suggested he'd already decided to support this. Detailed. Include curriculum outline, resource requirements, projected costs, potential revenue streams from other hospitals wanting access to the training. Most importantly, include measurable outcomes we can demonstrate to hospital administration. Patient survival rates, time to critical interventions, physician confidence in managing complex trauma. Maya was already mentally organizing the proposal structure. How soon do you need it? Take a week. Get it right rather than rushing. Wilson stood preparing to leave. But Maya, I want you to think bigger than just filling your time while waiting for credentialing. What you're proposing could transform how civilian medicine integrates combat medical expertise. It could create opportunities for hundreds of veterans trying to transition. And it could save lives by spreading knowledge that currently exists only in people who've deployed. After Wilson left, Maya sat alone in the staff lounge for several more minutes. Her coffee had gone completely cold, but she didn't notice. Her mind was racing through curriculum design, learning objectives, assessment strategies. All the educational infrastructure she'd need to build to make this vision real. For 8 months, she'd been focused on getting back to practicing medicine at her actual capability level, navigating bureaucracy to prove she could do work she'd been doing for years. It had felt like running in place, expending enormous energy without making meaningful progress. But this was different. This was about creating something new rather than just reclaiming something lost, taking the hardest experiences of her life and transforming them into lasting value that could help people she'd never meet. Maya pulled out her laptop and opened a new document. Combat Trauma Integration Program, she typed as a working title. Comprehensive curriculum proposal. The words flowed surprisingly easily once she started. Years of writing operational plans and after-action reports had given her facility with structured documentation. She outlined learning objectives for different experience levels, identified specific procedures and recognition patterns to teach, sketched assessment methods and metrics for measuring program effectiveness. She was so absorbed in the work that she didn't notice Dr. Harrison entering the staff lounge until he was standing directly beside her table. Working on something important, he asked. The program director, Wilson, suggested. Maya gestured to her screen filled with outline notes, formalizing the combat trauma training into something systematic and sustainable. Harrison pulled up a chair without being invited, leaning to read over her shoulder. This is ambitious. His tone carried respect rather than skepticism. Creating an entire curriculum and fellowship program. You really think there's enough unique content from military medicine to justify this? Maya turned her laptop so Harrison could see the full outline. I've identified 47 distinct clinical scenarios that military medicine encounters regularly. but civilian practice sees rarely, if ever. Each one has specific recognition patterns and treatment algorithms that could improve civilian outcomes. That's just scratching the surface of what could be taught. Harrison scanned through her notes, his expression growing more engaged. You're not just teaching procedures. You're teaching a completely different approach to clinical reasoning under pressure. Exactly. Maya felt validation hearing her vision articulated by someone else. Military medicine operates in resource-constrained environments with no backup. You develop systematic assessment methods that prioritize what kills fastest. That mindset has value in civilian emergency medicine, even though the specific context is different. I want to help, Harrison said abruptly. Not just as the supervising physician for your credentialing. I want to be involved in developing this program. Bring the civilian emergency medicine perspective to balance your combat experience. Maya studied him carefully. 2 weeks ago, he'd been mocking her tattoo and dismissing her clinical judgment. Now he was volunteering to partner on building an educational program. The transformation was remarkable. Why, she asked directly, why invest your time in this? Because what you did 2 weeks ago fundamentally changed how I think about my own expertise and limitations. Harrison's response was honest without being self-deprecating. I've spent my career assuming my training was comprehensive, that my credentials meant I knew what I needed to know. You showed me there are entire domains of medical knowledge I haven't even encountered. That's humbling, but also exciting. There's so much more to learn. Maya considered the offer. Having a civilian emergency medicine perspective would strengthen the program, make it more accessible to physicians who hadn't deployed, help translate military concepts into language civilian medicine understood. Okay, she said after a moment of evaluation. Let's build this together. Your civilian expertise combined with my combat experience. That's probably stronger than either perspective alone. They spent the next hour working through curriculum details. Harrison raised questions Maya hadn't considered about how civilian physicians would receive certain concepts. Maya explained military medicine approaches that Harrison had never encountered. The collaboration was productive in ways neither had fully anticipated. By the time Maya's shift started, they had a rough curriculum outline that covered 6 months of progressive training. From basic pattern recognition through advanced procedures. From individual patient management through mass casualty scenarios. From technical skills through clinical reasoning under extreme pressure. Maya felt something she hadn't experienced since leaving the military. The sense that she was building something larger than herself. Something that would persist beyond her individual contribution. Something that gave meaning to experiences that had often felt meaningless in their brutality. Her tattoo caught her eye as she pulled on fresh scrubs. The eagle and stars and medical cross that Dr. Harrison had mocked 2 weeks earlier. The symbols that Director Wilson had immediately recognized. The design that told a story of expertise earned through the hardest possible lessons. She'd spent 8 months hiding that tattoo, covering it with long sleeves when possible, downplaying its significance when asked, trying to blend into civilian medicine without drawing attention to her military background. But maybe that had been the wrong approach. Maybe the value wasn't in hiding her experience, but in sharing it. Not to prove her own competence, but to help others develop skills that could save lives. The emergency department was beginning its evening surge. Ambulances arriving, patients presenting, the constant flow of human crisis that defined this work. Maya moved into it with renewed sense of purpose. She wasn't just a nurse waiting for credentialing approval anymore. She was building something, creating a bridge between military and civilian medicine that could help veterans transition while improving civilian trauma care, taking the worst experiences of her life and transforming them into something that could generate lasting value. Director Wilson had been right. Teaching wasn't just filling time. It was finding new purpose, not replacing what she'd lost when leaving the military, but creating something different that honored what she'd learned there. Maya touched her tattoo one more time as she headed into the emergency department. Not hiding it, not ashamed of it. acknowledging what it represented about her past and what it was enabling for her future. The ridiculous tattoo was becoming a symbol of something larger, a reminder that expertise came in unexpected forms, that assumptions were dangerous, that sometimes the quietest person in the room carried knowledge that could change everything. 3 months until her credentialing review. 3 months to develop the curriculum. 3 months to prove that combat trauma expertise had systematic value in civilian medicine. Maya was ready. For the first time since separating from the military, she felt like she wasn't just surviving transition. She was building something meaningful from it. The work was just beginning. 3 months later, the hospital's main auditorium was filled beyond capacity. Medical staff from Seattle Grace occupied the front sections, but Maya could see attendees from at least 8 other regional hospitals filling the middle and back rows. Word about her combat trauma training program had spread through the Pacific Northwest medical community faster than anyone had anticipated. Maya stood backstage reviewing her presentation notes one final time. Her hands were steady, muscle memory from briefing senior military leadership before major operations. But she felt the familiar pre-mission tension settling into her shoulders. This wasn't life or death in the immediate sense, but it mattered in ways that extended far beyond this single presentation. 5 minutes. The audiovisual technician called from the control booth. Dr. Harrison appeared beside her, holding 2 cups of coffee. Thought you might need this before you go on. Maya accepted gratefully, wrapping both hands around the cup's warmth. Over 3 months of working together, Harrison had transformed from antagonist to genuine partner. His recommendation to the medical board had been instrumental in accelerating her credentialing review. His willingness to publicly acknowledge his own learning curve had given legitimacy to her teaching that purely military credentials couldn't have provided alone. Nervous, Harrison asked. Always before a major brief, Maya admitted. But this is productive nerves, the kind that sharpens focus rather than creating paralysis. Your credentialing came through officially, right? I saw the email from the board yesterday. Maya nodded, touching the new hospital badge clipped to her white coat collar. It read, Dr. Maya Rodriguez Trauma Surgery and Emergency Medicine in crisp black letters. 3 months of intensive bureaucratic navigation, countless forms and interviews and documentation submissions. But finally, official recognition of expertise she'd been practicing for over a decade. Congratulations, Dr. Rodriguez. Harrison's smile was genuine and carried none of the condescension that had characterized their first interactions. Though you earned that title years before the paperwork caught up with reality. 2 minutes. The technician's voice pulled Maya back to immediate focus. She took a deep breath, centering herself the way she always had before mission execution. This wasn't a briefing before combat deployment, but the underlying principles remained identical. Clarity, confidence, purpose. Know your material. Understand your audience. Deliver information that could save lives. The auditorium lights dimmed. Maya walked onto the stage to polite applause, taking her position at the podium. The projection screen behind her displayed the title of her presentation. Combat Trauma Protocols for Civilian Emergency Medicine. Lessons from 3 deployments. Good afternoon. Maya's voice carried clearly through the sound system. I'm Dr. Maya Rodriguez, trauma surgeon here at Seattle Grace, and formerly Senior Medical Officer for Special Operations Task Force 31 in Afghanistan. She paused, letting that introduction settle over the audience. 3 months ago, revealing her military background had been terrifying. Now it was simply fact. Context that explained what she was about to share. I want to discuss what military medicine can teach civilian practice. Not to suggest combat medicine is superior, because it's not. But it is fundamentally different in ways that offer valuable insights for emergency and trauma care in any setting. Maya clicked to her first slide showing survival statistics from military trauma systems. During 20 years of conflict in Iraq and Afghanistan, military medicine achieved trauma survival rates exceeding 97% for wounded personnel who reached medical treatment. That's unprecedented in warfare history and represents systematic innovation developed under the absolute worst conditions imaginable. She advanced through slides showing specific protocols, each one developed through repeated exposure to injury patterns civilian medicine rarely encountered. These protocols emerged from necessity. When you're treating blast injuries in a forward operating base with limited resources and no backup within hundreds of miles, you develop approaches that prioritize rapid pattern recognition and decisive intervention over lengthy diagnostic workups. The presentation walked through specific cases anonymized but detailed enough to convey clinical reasoning. The soldier with cardiac tamponade, who survived because Maya recognized Beck's triad within 90 seconds of arrival. The mass casualty event where systematic triage protocols saved 15 lives by correctly prioritizing salvageable casualties over expectant ones. The complex vascular injury repaired in a helicopter during medical evacuation because waiting for a proper operating room would have guaranteed death. Each of these cases taught hard lessons. Maya's tone carried weight of experience and loss. What we learned can translate to civilian medicine, not to replace existing protocols, but to enhance them, particularly for high-acuity trauma and mass casualty situations that overwhelm standard approaches. She clicked to a slide showing the proposed Combat Trauma Integration Program structure. This is what we're launching here at Seattle Grace, a formal curriculum that takes military-derived protocols and systematically adapts them for civilian emergency medicine application. The program details unfolded across multiple slides. Hands-on simulation training using scenarios based on actual combat casualties. Case-based learning modules built around pattern recognition rather than rote memorization. Advanced procedure workshops teaching techniques like emergency pericardiocentesis and damage control surgery approaches. Mass casualty preparedness drills that stressed systems beyond normal capacity to identify weaknesses. We're also creating a fellowship program specifically for military veterans transitioning to civilian medicine. Maya's voice carried conviction built from personal experience. Many of us face significant credentialing challenges because our training doesn't follow traditional pathways. This program will provide structured transition support while simultaneously bringing combat medical expertise into civilian healthcare systems that desperately need it. She paused, making deliberate eye contact with different sections of the audience. This was the moment that mattered most. Not statistics or protocols, but underlying philosophy that gave everything else meaning. 3 months ago, I saved a patient's life in our emergency department using techniques I developed during 3 deployments to Afghanistan. I was working as a floor nurse at the time because my military credentials hadn't been properly recognized by civilian licensing systems. That patient survived because someone, Director Wilson, was willing to look past surface assumptions and create space for me to contribute at my actual capability level. Maya's voice strengthened. How many other veterans with critical expertise are being overlooked right now? How many emergency departments are missing opportunities to learn from people who've managed trauma in conditions most of us can't imagine? This program addresses that systemic failure, creating infrastructure that values diverse experience and ensures expertise gets utilized regardless of where it was originally developed. The presentation continued for another 25 minutes. Maya fielded questions from the audience with the same calm confidence she'd brought to combat medicine. These weren't people being polite. They were genuinely engaged, already calculating how to implement similar programs in their own institutions. When she concluded, the applause was immediate and sustained. Maya stepped away from the podium, feeling the familiar post-mission exhaustion. Good fatigue, the kind that came from meaningful work, executed well. Later that evening, Maya's first official shift as a credentialed attending trauma surgeon felt simultaneously familiar and profoundly different. The emergency department was the same physical space where she'd spent 8 months as a nurse, but her role had fundamentally transformed. Instead of restocking supplies, she was leading resuscitations. Instead of following others' orders, she was making critical decisions. Dr. Rodriguez, incoming trauma. Jennifer Park's voice carried across the emergency department with easy professional familiarity. Motor vehicle accident, multiple casualties, estimated arrival 4 minutes. Maya moved immediately toward Trauma Bay 1, her mind already running through preparation protocols. Dr. Harrison joined her, and they performed the pre-arrival checklist together with practiced efficiency. Equipment verification, team briefing, role assignments, the collaboration they'd developed over 3 months of working side by side. The paramedics arrived with controlled urgency. 2 patients both ejected from vehicle at highway speed. First patient is male, approximately 40 years old, Glasgow coma, scale. 12, obvious head trauma with significant mechanism. Maya took primary responsibility for the more critically injured patient while Harrison managed the second. It was exactly the collaborative approach they'd refined, leveraging both civilian training and combat experience, each physician bringing complementary strengths to complex situations. The resuscitation unfolded with smooth efficiency. Maya's pattern recognition activated immediately. Subdural hematoma, likely given mechanism, and neurological presentation, but also concerned about potential cervical spine injury and internal bleeding from the ejection mechanism. She worked through systematic assessment, ordering imaging and laboratory studies while stabilizing the patient for definitive treatment. 30 minutes later, both patients were stable and being transported to their next level of care. Operating room for one, computed tomography for the other. The trauma team dispersed with satisfaction of crisis successfully managed. "Nice work on that C-spine call," Harrison said, stripping off contaminated gloves. That subtle right-hand motor weakness would have been easy to miss. Could have resulted in catastrophic cord injury if we'd mobilized him without precautions. "You caught it within seconds once I mentioned the possibility," Maya replied. "Multiple perspectives, different training backgrounds. That's exactly why this collaborative model works." A commotion at the emergency department entrance interrupted their debrief. A young woman in Army combat uniform stood awkwardly near the triage desk, obviously uncertain. Maya recognized the body language immediately. Recently deployed soldier, probably still adjusting to stateside rhythms, hesitant to seek medical care for reasons that combined military culture with personal pride. Maya approached carefully, keeping her voice gentle but professional. "Hi, I'm Dr. Rodriguez. Can I help you?" The soldier, a specialist based on her rank insignia, looked up with that particular combination of determination and vulnerability Maya knew intimately from her own transition. "I probably don't need to be here. It's nothing serious, really. Why don't we let medical professionals make that assessment?" Maya kept her tone supportive without being condescending. "What brought you to the emergency department tonight?" "I've been having these chest pains. Started maybe 3 weeks ago. Probably just stress or anxiety or whatever. But my platoon sergeant told me to get it checked out, so here I am." Maya noted several concerning clinical indicators immediately. The soldier's color wasn't quite right. Slight diaphoresis despite cool evening temperature. Breathing patterns subtly labored. These weren't anxiety symptoms. This was something requiring immediate evaluation. "When you describe chest pain, can you be more specific about the character and location?" As the specialist explained her symptoms in greater detail, Maya's clinical assessment crystallized rapidly. This wasn't anxiety or stress. This was likely pericarditis, possibly post-deployment related to untreated infection or inflammatory condition that had developed downrange. Serious and requiring immediate treatment, but manageable if addressed appropriately. "Let's get you properly evaluated." Maya gently guided the soldier toward an examination room. "And for what it's worth, your platoon sergeant was absolutely right to send you here. These symptoms aren't something to ignore or minimize. You sound like you know what you're talking about." The specialist's tension eased slightly, responding to Maya's evident understanding. "I spent some time in uniform myself." Maya smiled slightly. 3 tours downrange. "Where were you deployed?" "Kandahar province mostly. Some time in Helmand toward the end of my rotation. Same general area. Different years probably, but definitely the same dirt." Maya began her physical examination while maintaining conversational connection, a technique she'd learned in combat medicine for keeping patients calm during assessment. What's your military occupational specialty? 68 Whiskey, combat medic. Maya's examination confirmed her initial clinical suspicion. Pericarditis, moderate severity based on physical findings and symptom description, requiring immediate treatment and close monitoring but not immediately life-threatening if managed appropriately. As she explained the diagnosis and treatment plan, she watched relief wash visibly over the soldier's face. The fear of serious illness combined with guilt about potentially wasting medical resources. Both emotions Maya understood intimately from her own experiences. "Doc, can I ask you something?" The specialist's voice carried cautious curiosity. "That tattoo on your arm, is that what I think it is?" Maya glanced at her forearm, where her white coat sleeve had pulled back, exposing the eagle and stars and medical cross design. Special Operations Medical Leadership Course. Graduated 2019. Eeksy. Holy shit. The specialist's eyes widened before she caught herself. "Sorry, ma'am. I mean, you're one of those surgeons. The ones we heard stories about downrange. The ones who could operate on our guys in impossible conditions and save them when anyone else would have given up. We did what we had to do," Maya said quietly. "Just like you and your unit did what you had to do. Different roles, same mission. Bringing everyone home alive." As Maya left the examination room to arrange the specialist's hospital admission for monitoring and treatment, she felt something profound settle into place. This was what her experience actually meant. Not just technical skills or pattern recognition abilities, but the capacity to connect with veterans who needed someone who genuinely understood. To see past the military stoicism and recognize when someone was struggling. To provide care that acknowledged both medical needs and the unique context of military service. She found Director Wilson in his office well past normal administrative hours, reviewing reports despite the late evening. He looked up when Maya knocked on his open door. "Shouldn't you be off shift by now?" Wilson asked with mild amusement. "Could ask you the same question." Maya leaned against the doorframe. "Just wanted to say thank you again. For everything you've done to make this possible." Wilson waved dismissively. "You did the actual work. I just made some strategic phone calls and navigated bureaucracy. You recognized my tattoo when everyone else dismissed it as ridiculous." Maya's voice carried firm conviction. "You gave me permission to help when institutional policy suggested I shouldn't. You advocated for my credentialing when it would have been easier to let me remain a nurse indefinitely. That wasn't just phone calls. That was believing in someone when they couldn't quite believe in themselves anymore." Wilson was quiet for a long moment. "I've been in military and civilian medicine long enough to recognize genuine talent when I encounter it. And I've watched too many exceptional people get destroyed by bureaucratic transition processes. You deserved better than what the system was providing. The fellowship program is generating significant interest from other institutions." Maya shifted the conversation slightly. "I've had inquiries from 6 Level 1 trauma centers asking about implementing similar programs. This could actually become something much larger than we initially envisioned. It already is significant." Wilson replied immediately. "You're creating sustainable infrastructure bridging military and civilian medicine that hasn't existed before in any systematic way. That matters for veterans trying to transition. But it also matters profoundly for civilian medicine. We desperately need those perspectives and that expertise and those hard-earned lessons." Maya thought about the specialist she'd just treated. About Dr. Harrison's transformation from arrogant surgeon to engaged, collaborative partner. About her own journey from hidden credentials to recognized expertise. And beyond that, to creating educational programs that could help others. "It's strange," she said softly. 3 months ago, I was trying so hard to blend in, to avoid drawing attention, to navigate bureaucratic systems quietly without making waves. And now I'm standing in auditoriums teaching hundreds of physicians about combat medicine. Sometimes I'm not entirely sure which version of myself is actually real." Both versions are completely real. Wilson's response was immediate and carried absolute certainty. The Maya who needed time and space to adjust to civilian life was real. The Maya who's confident enough now to teach others is equally real. You're allowed to be complex and contain multitudes. That's fundamental to being human rather than a two-dimensional character. Maya nodded slowly, accepting the wisdom in those words. She'd spent so long trying to be one simple thing: soldier or civilian, surgeon or nurse, confident or uncertain. Maybe the truth was she could embody all those contradictions simultaneously without any of them being false. "Go home," Wilson said, not unkindly. "Get actual sleep. You have another training session tomorrow, and I suspect you'll want to be mentally sharp for it." As Maya left the hospital, walking through the parking structure toward her truck, she felt the accumulated weight of 3 months settling over her. So much had changed since that night when she'd performed emergency pericardiocentesis and shattered her carefully maintained anonymity, her credentialing, her role, her confidence in her place within civilian medicine, her sense that maybe transition wasn't about becoming someone different, but about finding ways to integrate all the pieces of who she'd been into something new. She paused at her truck, looking back toward the hospital building. Through the windows, she could see the emergency department still brightly illuminated. Constant motion of healthcare, continuing regardless of hour or exhaustion. Lives being saved, suffering being addressed, the endless cycle of crisis and recovery and healing. Maya touched her tattoo one final time, not hiding it anymore, not ashamed of it, acknowledging fully what it represented. Not just her past, but her future. The bridge between who she'd been and who she was actively becoming. In the end, Dr. Harrison had been profoundly wrong. The tattoo wasn't ridiculous. It was a reminder that expertise came in unexpected forms. That service continued beyond uniform. That sometimes the most valuable contributions came from the most unexpected sources and the quietest voices in any room. Maya Rodriguez had spent 3 years in Afghanistan, earning the right to wear that tattoo through experiences most people couldn't imagine. She'd spent 3 months at Seattle Grace, proving that its meaning extended far beyond military contexts into civilian medicine. And now, she had the opportunity and the platform to demonstrate what it truly represented. Not just individual capability, but the power to transform systems, to share knowledge across institutional boundaries, to create lasting change that would save lives she'd never personally touch. The tattoo remained unchanged. Everything else had transformed completely. And that Maya thought as she drove home through quiet Seattle streets was exactly how meaningful growth actually worked. 1 year later, the Combat Trauma Integration Program had expanded beyond anyone's initial projections. 12 hospitals across the Pacific Northwest now participated actively in the fellowship program. 23 veteran physicians had successfully transitioned to civilian practice through the structured credentialing support Maya and her team had developed. Patient outcomes in participating emergency departments showed statistically significant improvements in high-acuity trauma cases and mass casualty event management. Dr. Harrison co-directed the program alongside Maya, bringing civilian emergency medicine perspectives that balanced her combat experience perfectly. Their partnership had become a model throughout the region for how different expertise could complement rather than compete. And Maya Rodriguez, once dismissed as a floor nurse with a ridiculous tattoo, was now recognized nationally as one of the leading voices in trauma medicine integration. Her work had been featured in major medical journals, highlighted at national conferences, used as case study material in courses addressing veteran physician transitions. But the moment that mattered most came on a quiet Tuesday evening when a young veteran walked into Seattle Grace's emergency department. He was struggling with post-traumatic stress and wondering whether his combat medical training had any real value in the civilian world he didn't quite understand yet. Maya met with him personally in a quiet consultation room. She showed him her tattoo without explanation, at first letting him recognize the symbols. Then she told him her story. The struggles and the breakthroughs, the the rejections, and the eventual recognition. The transformation from hidden competence to acknowledged expertise to something larger than personal success. And she helped him understand something crucial, that his experience wasn't just valuable in abstract ways. It was essential. That civilian medicine desperately needed what he knew, that his service could continue in different forms. That transition wasn't about abandoning who he'd been, but about finding new ways to apply everything he'd learned. Because in the end, that's what the tattoo really meant. Not ridiculous decoration, but powerful reminder that every person's expertise tells a story worth hearing, that assumptions are dangerous and appearances deceive, that sometimes the quietest person carries knowledge that can change everything, and that stories, when shared with purpose and courage, can save lives far beyond the immediate moment. Maya's journey had come full circle. From combat surgeon to dismissed nurse to credentialed attending to program director, creating pathways for others. The tattoo that had been mocked had become a symbol, not of past glory, but of ongoing commitment to service that transcended any single role or institution. The work continued. It always would. But now Maya faced it with something she'd been searching for through 8 difficult months of transition: purpose, community, hope, and the deep satisfaction of knowing that the hardest experiences of her life were being transformed into lasting value that would help people she'd never meet face challenges she'd never personally witness. The tattoo remained the same. Everything else had become something better than she'd imagined possible.